Thank you. Good morning, everyone. Okay, so this is going to be 1 hour, very, very rapid bone and soft tissue pathology review. Um, Again, this is very similar to what I do at the Chicago Path Society and a compressed version of what we do for Osler. So please type in the chat. Here we go. So we're going to start with bone. Um,
I'm not sure if it's my connection, but I think you're going in and out. I'm not sure if anyone else has that.
from day to day, one of the m- most I do not know what happened. I'm sorry. I think I got kicked off. Okay, here we go. All right. One of the most important junctures is that frozen section where if we are not sure and we call something benign, they will curette and they will contaminate the field. Um, And so if you are ever unsure, be cautious and say, I don't know, because then they will stop. Once they've curetted and contaminated, if it ends up being malignant, the patient is no longer eligible for limb sparing surgery. So just something to consider in your practices when you grow up and have to do frozens. Caution is your friend. Okay, so we'll talk about various types of tumors, and I'm going to go through them pretty rapidly, but for each slide, there'll be some images, there'll be a long like description on the bottom, but like the critical things that we need to know points are in these like little white boxes in the center of the field. So the most common primary bone tumor is an osteochondroma, sometimes clinically referred to as an exostosis, although exostosis is a little bit of a generic lump all term, so we don't like to use it. Osteochondroma is a cartilaginous neoplasm that occurs in endochondrally ossified bones that induces bone growth under it. And the induced bone is in continuity with the bone of the marrow in the normal marrow space. And in patients who have multiple hereditary exostosis, these are the patients that have risk for malignant transformation to chondrosarcoma. The way that these are organized is as a sort of outer fibrous layer, a middle cartilaginous cap that we always measure, right? Always measure the thickness of the cartilaginous cap. And then third is that bone underneath it. The reason we measure the thickness of the cartilaginous cap is because it grows outwardly and the cartilaginous cap increases in size with malignant transformation. So you can see here how giant and lobulated and sort of cauliflower-like that osteochondroma is. That's malignant change. So it grows outward rather than inward. Um, the second lesion is BPOP or bizarre parosteal osteochondromatous proliferation, which is probably a kind of a hematoma of a complex or organization of woven bone, of cellular cartilage, and of fibrous tissue that's usually present on the small phalangeal bones. You can see here it is not in continuity with the marrow. It kind of causes this thickened rim of cortical bone. And it's generally this haphazard proliferation of those three things. Enchondroma is our intramedullary, right, proliferation of usually hyaline cartilage lobules that can undergo peripheral ossification, hence resulting in this stippled appearance on radiograph. By definition, it should not entrap pre-existing lamellar bone, otherwise it would be a chondrosarcoma. These can have IDH1 and IDH2 mutations, which do not differentiate them from intramedullary chondrosarcoma. Um, and specifically, if these can occur in the digits, they can be somewhat more cellular, but you should always see retention of the peripheral bone without bony entrapment. If you start to see bony entrapment, then you're dealing with a conventional chondrosarc. These tend to be somewhat more myxoid, but also can be hyaline in appearance. Um, by definition, they must entrap and penetrate through pre-existing lamellar bone, as you can see here. And again, they have IDH mutations, so it does not distinguish them from benign. They can, oops, I don't have this slide here, but for grading, it's generally grade 1, grade 2, grade 3 with increasing cellularity and atypia. And finally, DDIF, as pointed out here, is an abrupt transition to an undifferentiated spindle cell sarcoma. Clear cell chondrosarc is one of the rare epiphyseal tumors in adults. This is a proliferation of clear cells with islands of neoplastic cartilage in the background. And just like others, can dedifferentiate. Mesenchymal chondrosarc, rather than being clear cells and cartilage islands, it is spindly, very blue cells and cartilage islands that tends to happen in the jaws of teenagers. It has NCOA 2-Hey1 fusion and generally poor prognosis. Chondroblastoma is an epiphyseal tumor in young or skeletally immature patients. It tends to have these kind of mononuclear cells with these wrinkled or sort of coffee bean shaped nuclei in a background of myxochondroid matrix with this chicken wire calcification, as you can see on the bottom. And then in your giant cell rich tumor differential, this is one of them. It does have these osteoclast-like giant cells in the background seen in this blue circle. And it is positive for the histone K36M mutation. So this is one of the ones that does have an immunostain that can be pruvative if need be. Chondromyxoid fibroma, also in young patients, but in this case in the metaphysis and eccentrically placed, composed of these very lobulated myxoid cartilaginous proliferations with peripheral hypercellularity at the edges of the lobules. And it is in these peripheral hypercellular areas that you can see these osteoclast-like giant cells. So remember, in most mesenchymal neoplasms, the giant cells are bystanders, not neoplastic. They just come along for the ride, and this is no exception. Non-ossifying fibroma is the most common cause of pathologic fracture in children. You know, sometimes the boards like to ask these, what is the most common this and the most common that? So if there's ever a statistic such as that, I've kind of tried to put it in there for you. This is eccentrically located as this kind of soap bubble appearance. And on histology, it basically looks like a fibrous histiocytoma or a dermatofibroma of bone with these spindled or storiform patterned cells with osteoclast-like associated giant cells and essentially minimal to no intralesional bone because it is a non-ossifying fibroma. GCT or giant cell tumor of bone, again in skeletally usually mature, but also kind of spanning the spectrum of immature to maturity for age, located around the knee. The neoplastic cells are the background mononuclear cells that have nuclei that resemble the nuclei of the giant cells, so kind of wrinkled with small nuclei. This is unlike this is often compared to chondroblastoma because chondroblastoma, the nuclei are not like the nuclei of the giant cells. They're more of that kidney bean shape, as we discussed. This has the histone G34W, so a different histone mutation, but also has an immunostain. These can be locally destructive. They can even occasionally metastasize because they can enter blood vessels, but they are usually not fatal. They can be treated with rank ligand inhibitors, specifically denosumab, which essentially induce maturation. So pre-treatment on the left, post-treatment on the right, you can see how the giant cells regress because their signal to the mononuclear cells is blocked. And you just basically get induction of bone with absence of any background lesional cells. Once you remove the denosumab, though, the lesion comes back. Also on the differential of a giant cell rich tumor is aneurysmal bone cyst. characteristically, right, you will see or hear the term fluid levels, meaning sort of blood on blood or blood on serum on MRI. If it's a cystic lesion, because as you know, you can also get solid variants of aneurysmal bone cyst. Um, again, in teens, again around the and in the walls of the cyst, you have this kind of spindle cell proliferation, occasionally with pinkish osteoid, sometimes with this so-called blue bone that you can see here on the inset. Giant cells jumping off into the void, like lemmings, and USP6 gene rearrangement can be provative if you need it, if the morphology is not clear. On the radiographic differential is sometimes telangiectatic osteosarc because this can be cystic, this can have fluid levels, but it's often infiltrative destructive with cortical destruction. And on histology, you can see that the walls are not bland fibrous spindle cells, but they are in fact ugly malignant neoplastic cells with mites, with prominent nucleoli, with wrinkling, with hyperchromasia, etc. Other giant cell rich lesions include brown tumor of hyperparathyroidism and giant cell reparative granuloma, which are morphologically quite similar. There are these lobulated growths of mononuclear and giant cells with vascular kind of hemorrhage with hemosiderin. But the difference is in one, the patient should have evidence of hyperparathyroidism and nice bone resorption nearby with osteoclast destruction. And in the other, not so much. So always, consider PTH levels if you see something that's on this differential spectrum. Bilateral giant cell granulomas, as seen here, as cherubism. These kids' cheeks are puffed out like cherubs. Osteoma of bones, including of gnathic bones and long bones, basically sheets of nice mature lamellar bone. Think about Gardner syndrome if patient has multiple osteomas. Um, Here is osteoid osteoma, which is characteristically clinical pathologic, young adult, night pain, relieved by NSAIDs. Usually these are not even biopsied, not resected. They're radiofrequency ablated, so we don't usually see much, but this is an older case where it was resected, so you see nice woven bone with osteoblast rimming with this vascular stroma. They are generally, they have this nidus, as you can see here on radiology, with this intracortical clarity and small size FOS-B rearrangement. Similar but larger size and also FOS-B gene rearrangement is osteoblastoma. This can occur in either long bones or spine, less responsive to NSAIDs as osteoid osteoma. A little bit plumper osteoblasts with osteoblast rimming, again with vascular stroma. So basically, it's a matter of size, location, and clinical pathologic correlation that may differentiate osteoid osteoma from osteoblastoma. There are FOS immunostains that you can do if need be to help with diagnosis. Osteofibrous dysplasia is a lesion in the anterior tibial cortex, usually of a young male. You can see here these lesions on X-ray. This is one of the fibro-osseous lesions that has stroma that is variably cellular, that has spicules of bone that are variably shaped and sized with osteoblast rimming. And I like to compare them to ossifying fibroma of the jaws because they have similar morphologic appearance. So anterior tibial cortex, young male, think osteofibrous dysplasia. The differential here is an adamantinoma, and an adamantinoma can either look basically like a background of osteofibrous dysplasia with rare isolated clusters of epithelial islands that you can highlight on keratin stain, and you can see here with these arrows, versus a full-fledged classic adamantinoma that has giant epithelial islands that really look like that look like ameloblastoma. And so whenever you have an osteofibrous dysplasia, I would throw your keratin on there to see if you can pick up these isolated islands, in which case prognosis is a little bit worse because these can metastasize. Other fibro-osseous lesion, fibrous dysplasia, ground glass with sclerotic rim, classic appearance on radiology, monotonously cellular stroma, monotonous kind of curvilinear strands of woven bone without osteoblast rimming, with nice Sharpei fibers that imply that these kind of ossify right out of the stroma. Um, GNAS1 mutation may be present, and syndromes are listed down here. Differential here is intramedullary fibroblastic osteosarcoma that generally has these slightly more cellular stroma. The stromal cells should have some nuclear atypia, should have mitotic activity, and helpfully these are MDM2 CDK4 amplified. So you can use MDM2 CDK4 to help differentiate a low-grade well-diff fibroblastic osteosarc from a fibrous dysplasia, for example. Conventional osteosarc, however, is much more atypical, generally has enlargement, hyperchromasia, nucleoli. You should always see some amount of osteoid, even if it's very fine and wispy, in order to call something osteosarcoma. Characteristic teens around the knee, again, second peak in the elderly, or not, I guess 50 is not quite elderly because I'm, it'll be a number of years before I'll shut up now. Okay. Second peak in older patients, sometimes related to Paget's disease. We do not do SAPB2, just in case this shows up anywhere. SAPB2 just tells you that there's osteoblastic differentiation. It does not tell you that it's malignant, so we don't do it. Radiology shows Codman's triangle, which is a lifting off of the periosteum due to protrusion into the soft tissue through the cortex by sarcoma. So here's the periosteum that's elevated. Here's the cortex. That's Codman's triangle. Surface osteosarcomas are of parosteal or periosteal subtype. Both are kind of located at the periphery, usually of the distal femur. One of them, parosteal, is a low-grade fibroblastic osteosarcoma that again has MDM2 amplification, so that can be helpful. Periosteal is more of a chondroblastic osteosarcoma of low or at most intermediate grade, usually. These generally are treated primarily with resection, with clean margins, as opposed to the conventional osteosarc, which you just saw, which is treated with neoadjuvant chemo because it's highly chemosensitive. These two are not. So generally resection is primary. The number needed to treat, no, number of percent of treatment response for conventional osteosarcoma to infer good prognosis is what? Those of you who have signed this out, remember that it's 90% treatment effect is good prognosis. Okay, so there's your slide on parosteal. There's your slide on periosteal. Okay. Other things that we can see in the bone include things like Langerhans histiocytosis, which you know from your heme rotations are these histiocytes with folded or beanie nuclei, with lots of EOs in the background, CD1A, Langerhans, S100. Occasionally, BRAF V600E is positive, so we can use that as well. Burbeck granules, no one does EM anymore, but historically, we know that they exist. Our small round blue cell tumors of bone mostly are on the spectrum of Ewing's or Ewing's-like tumors. Remember that Ewing's can occur in kids, but it can also occur in adults. Small round blue cell tumor with CD99 diffuse strong positivity, FLI1, or ERG being the fusion partners. So nuclear expression of either FLI1 or ERG depending on partner. Okay, moving into soft tissue. So the books I like to use for soft tissue include those that have lineage of differentiation like Enzinger and Weiss and the WHO. I really like the histologic pattern book for those that are learning because you don't have to have a differential. You just have to kind of describe what you see and go to that chapter. And then, of course, combinations of both. Sometimes for sarcomas, there's questions on what metastasizes to lymph nodes. So I've put the tumors that we know most frequently go to nodes. All right, let's start with fat. So fatty tumors are going to be the most common tumor that you will see in soft tissue. Um, so normal fat has a sort of plump monovacuole with a plump kind of crescentic, not crescentic, what's the word, like corneal kind of shaped lens shaped fat nucleus. Lipoblasts, on the other hand, have nuclei that are indented right by the vacuole. So mononucleated monovacuolated, bivacuolated, or multivacuolated all indent the nucleus, as you can see here. Brown fat has multiple vacuoles that do not indent the nucleus. And sometimes fat necrosis can mimic lipoblasts because they can sort of shrink and have these histiocytes at the side. But, if you look carefully, you'll see this abundant cytoplasm and very open chromatin as opposed to the dark chromatin of liposblasts. So benign adipocytic tumors are listed here: lipoma, hibernoma being of brown fat, angiolipoma having clusters of capillary vessels, usually multiple, usually forearm, usually painful. This is probably a familial kind of inheritance. Fibrin thrombi in the lumen. Spindle cell or pleomorphic lipoma can be a challenging one. Classically, it's on the posterior neck or shoulder or back of older men. However, you can see pleomorphic lipomas kind of anywhere / spindle cell. Generally have ropey collagen, generally have these blunt, almost cigar-shaped spindle cells, often with palisading. Once you start to get hyperchromasia or floret cells, then you're in the spectrum of pleomorphic. These are related to loss of retinoblastoma, so you can do the RB stain if you want and see loss in the nuclei. Sometimes we count on CD34, but I think CD34 is positive in a lot of fibroblasts, so to me it's less helpful. But in the differential with ALT, atypical lipomatous tumor, MDM2-CDK4 would be negative. Lipoblastoma, we're talking present since birth, with myxoid background, with septations, with lipoblasts. If this is not resected, it can mature to basically almost looking like a mature lipoma. So if you see a mature lipoma in a young kid, always, check to see if it's been present since birth. It could be a lipoblastoma. Like pleomorphic adenomas, these have PLAG gene translocations. All right, once we get into our sort of locally recurring and malignant adipocytic tumors, I've provided the chart here for you. So spindle cell or pleomorphic lipoma can have this atypical variant that has increasing cellularity, myxoid stroma, hyperchromasia, mitoses, etc. This would now be an atypical spindle cell pleomorphic lipomatous tumor that still has RB loss. This is the kind of biologic equivalent of the conventional atypical lipomatous tumor that we see in the trunk and extremities, or well-diff liposarc, same tumor but in the retroperitoneum. Morphologic variants include fatty, sclerosing, inflammatory, or myxoid. When this goes bad, it goes to D-diff liposarc. This entire column is MDM2-CDK4 chromosome 12q. Myxoid liposarc, high-grade equivalent is round cell. This is FUS-DDIT3. And then pleomorphic liposarc has no low-grade component and no specific genetics. So here's what they kind of look like in parallel. ALT with these individual hyperchromatic cells, D-diff liposarc, hypercellular, mitotically active. Myxoid liposarc, myxoid stroma, lipoblasts, curvilinear blood vessels, and then round cells being exactly what they say they are. They are round without much cytoplasm with nucleoli with mites. 5% round cell is thought to be the cutoff for bad behavior. And then bottom right, pleomorphic, usually extremities of elderly, but again, no specific genetics. So here's your comparative chart. Remember that in your extremities, the column on the left in the well-differentiated form is always atypical lipomatous tumor in the retroperitoneum, of which the spermatic cord is a part. This is well-diff liposarc. D-diff, you have to have essentially fat-free with greater than 5 mitoses per 10 high-power fields. Myxoid and pleomorphic, if you get a round cell or a pleomorphic liposarcoma appearing tumor, but in the retroperitoneum, do your MDM2 CDK4 because it's probably just a round cell or a pleomorphic variant of D-diff. So location, 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 retroperitoneum, retroperitoneum, retroperitoneum is MDM2. Extremities can be any of these three. I've spent a lot of slides on liposarc because, again, this is probably one of the most common tumors that you will actually see in your practice. So I've left these slides here for you to review on your own because I think we've talked a lot about these already. Okay, moving into the myogenic tumors. Tumors of smooth muscle differentiation, of skeletal muscle differentiation, and of perivascular myoid differentiation. So let's start with leiomyosarcoma of the soft tissues, right? We are not dealing with that of the uterus, but we are dealing with the soft tissues. So in the retroperitoneum, or for that matter, other body sites, often these arise in conjunction with or adjacent to large vessels. We just had one the other day on BST service that was right attached to a vessel of the extremity. So whether it arises from the smooth muscle of the vascular wall, that's one theory of where these come from. They can aberrantly express keratins. They can, in fact, aberrantly express estrogen and progesterone receptors in the retroperitoneum, even if they are not of GYN tract origin, even if they are present in males. So do not use ERPR as an indication of site of origin. If the patient's immunocompromised, think about doing an EBV stain because these tend to have better behavior if they are, in fact, EBV positive. All right, rhabdomyomas, i.e. skeletal muscle differentiation. We have a number of variants. There's the cardiac one that has these sort of pale cytoplasm and spidery look. There's the adult extracardiac that has, excuse me, boy, yawny this morning, that has striations in the cytoplasm and these sort of eosinophilic inclusions. The fetal and the genital rhabdomyomas have more elongated or strap-like cells, also with possible striations. We're dealing with either the sort of genital area or the post-auricular area generally in the fetal type. But these are all quite rare. All right, but we do see rhabdomyosarcomas in kids. We're generally dealing with embryonal subtype in head and neck and GU area. The term botryoid just means it protrudes from an epithelial-lined organ in a grape-like appearance. You can see here on the bottom left the respiratory type epithelium with this so-called cambium layer of tumor cells, meaning tumor cells condensed right underneath the surface. Conventional embryonal rhabdo has this marbled appearance with pale areas and dark areas and kind of sweeping fascicles. You may, if you're lucky, see striations or rhabdomyoblasts with pink cytoplasm. MyoD1, myogenin, desmin will be positive. The stronger and more diffuse your MyoD1 is, the more you might be concerned that the patient has the variant of alveolar, which has the PAX-FOX gene fusions and more aggressive behavior. So for all intents and purposes, morphology of these two can be overlapping. What's critical is diffuse strong intensity for MyoD1, which is predictive of the PAX-FOX gene rearrangement, which is predictive of worse prognosis. So fusion testing or FISH or whatever is critical in all rhabdos to determine the presence of fusion for prognostic purposes. Classic alveolar morphology is nested with kind of larger cells with prominent nucleoli, and as you can see here, nice eccentric cytoplasm, eosinophilic rhabdomyoblasts. Other differential diagnosis of your kind of small round blue cell tumor, we already talked about rhabdo on the left. We talked about Ewing's in the bone on the right, which can also be primarily in soft tissue, which is why it occurs here. And then desmoplastic small round cell tumor. So this is highly characteristically in the intra-abdominal cavity, usually of a teenage male with multiphenotypic differentiation, namely epithelial, myogenic, neural, and then by definition, this is EWSR WT1. CD99 is more patchy, and the nuclear marker that would be positive would be WT1. it, as its name suggests, right, has this desmoplastic stroma, but otherwise small round blue cell tumor in between. This can occur outside the abdominal cavity, just FYI. Also in your small round blue cell tumor differential, depending on age, right, might be carcinoma and melanoma or lymphoma, especially if you're in an older adult population. Other small round blue cell sarcomas that are Ewing's-like include the chick ducts and the B-core. So we're either dealing with B-core most common in bone, so BB, and the chick ducts most common in soft tissue. These have CD99 expression that is less diffuse and less strong than conventional Ewing's, so let that be your guide. The morphology is often a little more microcystic or myxoid, so also let that be your guide. There are stains, but usually molecular, sequencing fusion testing will be confirmative. Pleomorphic rhabdo is generally a tumor of adults in the soft tissues of the trunk and extremities, with pleomorphism with rhabdomyoblasts. And interestingly, these can sometimes have MDM2 expression, but without gene amplification. So just caveat, because we know that D. diff liposarcs can have rhabdomyoblastic differentiation. If you have MDM2 expression, always try to confirm with FISH, because if it's not amplified, then it could still be a rhabdomyosarcoma. If it is amplified, then you're more dealing with a D. diff liposarc. Spindle cell or sclerosing rhabdo kind of almost looks like a smooth muscle tumor on low power. It's very long, fasciculated, eosinophilic. However, you do end up, in most cases, seeing these rhabdomyoblasts, which could be a clue to the diagnosis. Desmond and, in fact, myogenin, of course, as well as MyoD1 should be positive because this is skeletal muscle, right? So myogenin, MyoD1 specific for skeletal muscle differentiation. In kids, we're dealing with paratesticular region. In adults, deep soft tissue, head and neck usually. Here's the gross appearance, kind of whirly, almost like a lyo. Oops. And our last but not least, our perivascular myoid tumors. So remember that all normal blood vessels have pericytes around them that develop into the smooth muscle wall of vessels, right? Because all vessels need little contractile assistance. So it is the cells of parasitic differentiation that we're talking about here. So they are contractile, so they should have some kind of smooth muscle actin in all cases. If they are very well developed, like angioleiomyoma, they will also have desmin. They look like smooth muscle. All the way on the more primitive spectrum, glomus is very primitive, small round cell, kind of fried egg looking tumor. In the middle is your myofibroma, myoparasitoma spectrum that has usually a hybrid of more primitive appearing glomoid cells and more mature myogenic looking cells. All of these 3 tumors or 4 tumors are associated with blood vessels richly, right? Because they are perivascular myoid cells, so they have a prominent associated endothelial and vascular component. You can see here, nice blood vessel lumen with angioleiomyomatous, sort of cells whirling concentrically around the luminal opening. Okay. Moving into the actual vascular tumors, right? So these are the tumors of the perivascular myoid cells. These are now the tumors of the endothelial cells, ranging from benign to intermediate to full-on malignant. So infantile hemangioma, benign, rapid growth after birth, peaks and then regresses. If these are biopsied or resected in their proliferative phase, they can be extremely cellular, extremely plump endothelial cells, but very nicely organized into these lobules. And you can see GLUT1 here being positive in the cytoplasm slash membrane of the endothelial cells. Remember that GLUT1 transporter is also present on red blood cells, so ignore the RBCs in the lumen and focus on the peripheral endothelial cells. If you get this in the regressive phase, it might be somewhat more paucicellular with more stromal component. Epithelioid hemangioma, sometimes called angiolymphoid hyperplasia with eosinophilia, usually has very, very plump and somewhat scary, juicy looking endothelial cells, but these are always very well formed, They are not leaky, they are not anastomosing, and they do have their perivascular myoid layer around them. There's eosinophils, as the name suggests, in the background. The endothelial cells mark with what we would expect, CD31, 34 ERG, of course, SMA positive in the parasite if you want to demonstrate that layer. Unlike epithelioid hemangioendothelioma, so remember, hemangioendothelioma, or HE, is the term that is given to all the vascular tumors of intermediate malignant potential, meaning they can be very aggressive, locally recurring, and rarely metastasizing. EHE is non-vasal formative. It's formed of single cells and strands of cells and set in this myxoid to collagenous background with these vacuolated or sometimes called blister cells. If you're lucky, you'll see a red blood cell in the lumen of these blisters. That is the way that these are trying to form vessels. They're basically forming intraluminal kind of signet ring vessels. Like other epithelioid mesenchymal neoplasms, these can stain with keratin. They also will stain with your other endothelial markers. WWTR campta is the most common gene rearrangement. Multifocality in a single human being is likely metastases from a single primary. Another HE, pseudomyogenic HE, is interesting because it kind of looks fibroblastic, myofibroblastic, or myoid, and it in fact stains with smooth muscle actins as well as CD31s, as well as keratins and ERG. So kind of this hybrid vascular, epithelioid, and myoid immunoprofile. These are related to FOSB gene rearrangements. Very rare, but think about it if you have a weird co-expressing tumor. Differential diagnosis between sort of epithelioid hemangioendothelioma, epithelioid angiosarcoma, which we'll talk about momentarily, and just epithelioid sarcoma, right? Not vascular, which we will also talk about, is listed here because these are all epithelioid. These can all express keratin, and you're sort of differentiating between, are they vasoformative or not? Do they have vascular markers or not? And as we'll talk about shortly, INI1 loss in epithelioid sarcoma. All right, the first, conventional high-grade angiosarcomas. So there are a number of ways that angiosarcomas can develop. One is in sun-exposed skin, especially on the scalp of older patients. Two is deep soft tissue, which has no known causative agent. Primary breast angiosarcoma deep in the breast, also sporadic, versus radiation or lymphedema-related angiosarcomas secondary to either radiation or lymphedema in patients who've had breast cancer. These are related to MYC amplification. So morphologically, your primary cutaneous, your primary soft tissue tend to be vasoformative, tend to be high grade, versus your primary breast tend to be a little bit more, there it is on the bottom, more flattened endothelial cells, but highly infiltrative. And then your post-radiation angiosarcomas can be differentiated in the skin of the chest by MYC immunostain. There was just one of these that the breast service had. So if y'all want to see it, I think we have the slides somewhere. Okay. Kaposi sarcoma comes in various etiologic flavors, but morphologically is all the same. Spindle cells that are relatively streaming with extravasated red cells with eosinophilic hyaline globules and immunoexpression for HHV8, as well as your other endothelial markers. These can be related to HIV. It is an HIV, an AIDS-defining illness in HIV patients. Also immunosuppression from solid organ transplant. And then in non-immunocompromised patients in Africa and sort of Mediterranean regions in patients without HIV or without immunocompromised state. Okay.
Kaposi.
That's how you pronounce it in Hungarian. Thank you, Dr. Kraus.
Kaposi.
Okay, not Kaposi. All right, nerve sheath tumors. Nerve sheath tumors can develop in sort of mimicry of any component of the nerve sheath. So what is the nerve sheath? The nerve sheath is perineurium, which surrounds the entire sort of band of a nerve, right? These are positive for EMA, GLUT1, Claudin-1, CD34. Schwann cells being the sheath of the individual nerves, right? And the axons, those are Schwann cells are S100 and SOX10 positive. You can sometimes in nerve sheath tumors get actual axons interdigitating in them, and certainly supporting cells like vessels and fibroblasts. So we can have perineurioma, schwannoma, neurofibroma, which kind of has components of all of them, and then hybrid perineurioma schwannoma, which we will see. Malignant variant of all of them is malignant peripheral nerve sheath tumor that can sometimes show Schwannian differentiation, that can sometimes show perineurial differentiation. There are various morphologic types of schwannomas, ranging from the ancient with degenerative change to very cellular to plexiform, which is loosely associated with NF2, microcystic reticular schwannoma in the GI tract. Multiple schwannomas can also be associated with NF2 or schwannomatosis, which is SMARCB1 gene. Usually these do not transform to MPNST, except on rare occasion. A confounder here is your melanotic Schwannian tumor, which can mimic either a schwannoma because of S100 SOX10 expression, or a melanoma because of HMB45 melanA expression and significant melanin pigmentation. These are in the usually paraspinal region of adults. Some of these have Carney complex. They can metastasize, hence Schwannian tumor, as opposed to just pure schwannoma. But they used to be called melanotic schwannoma. Okay, here's an example of plexiform neurofibroma, which you know is pathognomonic of NF1. On gross appearance, it sort of is this multi-lobulated, quote unquote, bag of worms appearance. And on cut section, you can see these multiple tumor nodules, but also with diffuse neurofibroma kind of present in the background around these lobules. Hybrid sorry, no, this isn't hybrid. This is just plain perineurioma. Plain perineurioma tends to have storoform, very tightly packed storoform, fasciculated, kind of this nodular appearance, and expression of perineurial markers here shown EMA and CD34. Remember, Claudin-1 and GLUT1 also positive, but because these are not Schwann cells, right? These are S100 negative. These can be in various sites, including mucosal and soft tissue of extremities. MPNST can be of kind of conventional marbled morphology, kind of like rhabdo, or epithelioid morphology, or if it has rhabdomyoblastic differentiation, it's called a Triton tumor. Usually we're looking with something either transforming from a benign peripheral nerve sheath tumor like an NF1 or associated with a nerve. MPNSTs can be challenging to diagnose outside of this context because they often lack or are very only weakly positive for S100 SOX10. So always look for syndrome or look for association with nerve. Epithelioid ones tend to be more S100 positive. That is all I will say for now. Okay, moving into our last group of kind of fibroblastic, myofibroblastic. Again, if anybody has comments, please type them in the chat. Excuse me, otherwise I'm just going to keep going. All right, so one tumor that we always need to think about, because if you don't, you'll never diagnose it, but if you do, you'll often be right, is nodular fasciitis. So usually rapid growth, usually over the course of 2 to 3 months, sometimes with pre-existing trauma, generally smaller than 5 centimeters. This can be circumscribed or infiltrative, It generally has this wispy kind of tissue culture myofibroblast appearance. It can be highly mitotically active because it is rapidly growing, is related to USP6 gene rearrangement. And on next slide, I have high power of what the cells look like. So anywhere from myxoid microcystic on the top left to keloid-like collagen with extravasated red cells on the top right, very thin, wispy myofibroblasts on the bottom right, and then more cellular, younger, plump fibroblasts on the bottom left. So think about nodular fasciitis with this conglomeration of morphologies. And if you need to, do USP6. Other fasciitis are kind of defined by their location or clinical setting. So intravascular, cranial, proliferative with these ganglion-like cells, or ischemic in, of course, zones of usually pressure ulcers, pressure ischemia. So they all look kind of similar. It's just dependent on where they're located and how they arose. All right, fibromatoses. So most common fibromatosis you're going to see is desmoid tumor or deep fibromatosis. Um, Clinically often described as being in the abdominal wall of young, kind of reproductive age females, but certainly that is not only where they can occur. They can be associated with Gardner syndrome. They generally show low power, long, pale pink fascicles. They have an infiltrative appearance, which makes them very hard to excise. They are myofibroblasts, so they should be SMA positive. And if you're lucky enough to have a good beta-catenin immunostain, you can often see nice nuclear expression as well as some cytoplasmic staining here in this top right panel. They have the characteristic appearance of fibroblasts, right, with these very oval, elongated nuclei with small pinpoint nuclei and these kind of tapering, wispy cytoplasms. Okay. Other fibromatoses, aside from deep or desmoid, include superficial fibromatosis or Dupuytren's contracture in the palms. Remember, these can also be present in the soles, but they're in all cases diagnosed as superficial fibromatosis. They kind of look like desmoid tumor. They can have some associated giant cells in them, and they are usually stuck in the tendons of the palms and soles. Fibromatosis coli or torticollis we usually do not see because it is treated by physical therapy rather than excision. Juvenile hyaline fibromatosis is of autosomal recessive inheritance with these sort of rich eosinophilic material in the background. Infantile digital or inclusion body fibromatosis has these trichrome positive inclusions next to the nucleus on the digits of kids. And rarely we see lipofibromatosis, which is this combination of fat and fibrous tissue in distal extremities of kids. Just like the fibromatoses, the fibromas are of numerous colors and flavors. Please, we try not to ever diagnose fibromatosis or fibroma without some kind of qualifying word, right? So deep fibromatosis, superficial fibromatosis, fibroma of tendon sheath, Gardner fibroma, right? So they all have some kind of descriptor. Um, Fibroma of tendon sheath, usually distal extremities of adults, very collagenous rich. Sometimes they can be cellular, in which case they have USP6 rearrangement. Nuchal type fibroma, posterior neck of diabetics with this ropey collagen. Gardner fibroma, very sclerosing and entrapping of pre-existing structures like nerves, etc. Often in kids, you can show beta-catenin in the nucleus if you're lucky. They should get screened for FAP. Elastofibroma is present in elderly patients between the scapula and the chest wall. So sort of right posterior side of the body. You can show these beaded elastic fibers on elastin stain. Calcifying aponeurotic fibroma is this kind of granuloma appearing lesion in the distal extremities, palms of kids. It has this central calcifying or sort of chondroid matrix with peripheral histiocytes and or giant cells at the periphery, but it kind of looks like a granuloma, but the center is this calcified grungy debris. Okay, so moving into our hypocellular myxoid sarcomas, which terminologically can be challenging, so we're going to spend a minute on them. So myxo and fibro and sarcoma, and fibro and myxo and sarcoma are in the names of both of these. So on the left, LGFMS, low-grade fibromyxoid sarcoma, is by definition low grade, is usually in young adults, is generally well circumscribed, has discrete myxoid collagenous zones, as you can see on the bottom, and has Fuss-Krebs gene rearrangements. All right. In contrast, myxofibrosarcoma can be of any histologic grade. You have to use the French system, is generally present in elderly, is generally highly infiltrative, and has these multiple infiltrative nodules of these sort of more atypical spindle cells with uniformly myxoid stroma with curvilinear blood vessels and often atypical tumor cells clustering around the blood vessels. These do not have a specific immunoprofile or genetics, okay? Mostly, these are high grade, mostly, but sometimes they can be of lower intermediate grade on the French system. So LGFMS on the left, myxofibrosarc on the right. If you hear the term Evans tumor or hyalinizing spindle cell tumor with giant rosettes, that's LGFMS. LGFMS stains with EMA and MUC4, as you can see here. So that's highly specific. You may or may not see the collagenous rosettes, but there they are on the bottom left. Versus myxofibrosarc, more cytologic atypia, right, in terms of enlargement and hyperchromasia, and these curvilinear, nicely sort of robust blood vessels. Okay. LGFMS can transform, however, to a higher grade tumor called sclerosing epithelioid fibrosarc, which has a wide variety of appearances. It can be epithelioid in sheaths. It can be single file with very collagenous stroma. This collagenous stroma can sometimes resemble osteoid, so it can be mistaken for osteosarc. The single file appearance with keratin expression or EMA expression can sometimes mimic like a lobular breast cancer, okay? But again, try for MUC4 and try for Fuss-Krebs fusion. If it is pure sclerosing epithelioid fibrosarc in the absence of LGFMS, the fusion partner is EWSR instead of Fuss. That's the only difference. Table, review it on your own. All right, synovial sarc is a misnomer, has nothing to do with synovium, with the exception of sometimes it occurs near a joint. Mostly young adults, mostly this very, very richly cellular spindle cell storiform lesion with these thin-walled dilated blood vessels. Sometimes can be biphasic with these gland-like spaces, which are keratin positive. Whether it's monophasic or biphasic, you should have EMA expression. You should have the gene fusion of SS18, SSX. We no longer rely on TLE1 for diagnosis, but we now use the synovial sarcoma specific IHC, which we send out to Mayo because we don't have it in-house, but nice nuclear expression. These are generally not graded. They are generally of somewhat aggressive behavior. Okay. SFT, solitary fibrous tumor, prototypically a pedunculated mass off the pleural surface of the lung, however, can also arise in the deep soft tissues of the trunk and extremities, can certainly arise in the head and neck. We know this can happen in the sinuses. We also know this tumor happens on the meninges, where it used to be called hemangioparasitoma, but is no longer. It is, all of these are now SFTs, which are CD34 positive, STAT6 positive, reflective of NAB2 STAT6 fusion, which you can see based on nuclear IHC. Variably cellular to collagenous stroma, thin-walled dilated blood vessels. If they secrete IGF-2, they present with hypoglycemia. Essentially, all SFTs should be regarded as potentially malignant, and they should be graded according to the D'Amico criteria, which is based on size, age, margin status, hypercellularity, mitoses, etc. Okay. Inflammatory myofibroblastic tumor is another one of those that, kind of like nodular fasciitis, If you don't think about it, you'll never diagnose it because it's not going to scream at you. But when you do think about it, you'll probably diagnose it at some point. So, very nondescript myofibroblasts with associated inflammatory cells in a variety of patterns, including kind of with myxoid stroma, including with collagenous stroma and very scar-like, occasionally with these ganglion-like cells, all of which have a mixture of myofibroblasts and inflammatory cells. If you're lucky enough to have ALK expression, you've nailed it. Sometimes you have to do fusion testing for ALK rearrangement. And some of them just don't have ALK rearrangement, but are still IMTs. So keep a broad differential, keep an open mind with this tumor. They should have some immunomarkers of muscle differentiation. Okay, fibrosarcoma, I diagnose in two circumstances. One is infantile fibrosarc in young neonates with this highly cellular intersecting kind of fasciculated long herringbone pattern with ETV6 NTRK3 fusion, generally good prognosis. The other time we will diagnose fibrosarc is if you have a similar morphologic tumor that has transformed from DFSP. Generally, I will not diagnose fibrosarcoma in isolation in an adult. It's probably some other sort of differentiated sarcoma. However, if it arises from a DFSP, you've got it. But the morphology, again, is long herringbone, hypercellular, mitotically active. Okay. And undiff sarcoma is essentially a diagnosis of exclusion. It's basically stains for nothing except for maybe some myoid markers, myofibroblast-like markers. So basically prove that it's not some other type of differentiated sarcoma and move on. It's no longer called pleomorphic UPS because not all of them are wildly pleomorphic, but they should be hypercellular and mitotically active. Some of them have giant cells, some of them have round cells, et cetera, et cetera. Very common sarcoma in adults. And epithelioid sarc. So we mentioned epithelioid sarcoma previously in terms of a kind of a differential diagnosis with other tumors. It comes in two types, the distal or the classic type and the proximal type. Both have epithelioid cells that express keratin, that express EMA, that have loss of INI1 or SMARCB1 chromatin remodeling complex gene. In the distal extremities, they tend to look almost like these granuloma-like structures. In the proximal, they're just sheets of these ugly pleomorphic epithelioid cells. One of the ones, of course, that can metastasize to lymph node, probably sarcomas that, the way I conceptualize it is sarcomas that metastasize to lymph nodes are generally of epithelioid morphology and can have keratin. So maybe they've undergone some kind of mesenchymal to epithelial transition, which allows them to like get into blood vessels and travel. That's just, I don't know, my theory. Okay. However, your differential diagnosis with a distal epithelioid sarcoma that might resemble a granuloma include things like rheumatoid nodule in adults, which is just histiocytes and giant cells. Similarly, with granuloma annulare in the skin, histiocytes and giant cells. And as we saw earlier, calcifying aponeurotic fibroma, this is more going to be in a child. Of course, epithelioid sarc will be obvious when you stain it with keratin and EMA and INI1, because you will do that. Okay. Very, very is rhabdoid tumor. So we have renal rhabdoid tumor, obviously in the kidney. We have extrarenal rhabdoid tumor in the deep axial region of kids. We have CNS ATRT, all of which are similar high-grade epithelioid to rhabdoid tumors growing in sheets with loss of INI1. Some of these kids have germline SMARCB1 mutation, but essentially in all locations and under all guises, whether it be epithelioid sarcoma or extrarenal rhabdoid tumor, poor prognosis in all. So if you have an INI1 lost tumor, you're basically dealing with a poor prognostic situation. INI1 lost tumors are generally those that have some amount of rhabdoid cell component. Some of them are listed here. More are listed here. So whenever we have rhabdoid morphology or possible INI1 tumor, I always do both the INI and the BRG because if it's not one, sometimes it's the other. And we're now discovering that sometimes a tumor that was thought to have loss of one in small percentages can also have loss of the other. So they kind of work in concert. Um, these are the tumors that we know have loss of either one of these two markers. Please read it on your own time. Alveolar soft part sarcoma. Sorry, it's 9 o'clock. I'm almost done. Alveolar soft part sarcoma, as its name suggests, is nested, is epithelioid with abundant eosinophilic cytoplasm. These PAS positive rhomboid shaped granules. Really diagnostic is only TFE3 expression or TFE3 gene fusion. No other immunoprofile is reliable here. These can metastasize head and neck adults, young adults. Clear cell sarcoma, malignant melanoma of soft parts. So kind of looks like a melanoma, kind of stains like a melanoma with HMB45 and melan A, but S100 not so strong. So that could be a clue as to clear cell sarcoma. These do not have melanoma gene markers, gene profile, gene mutations. These have EWSR, ATF1 fusions. High grade, poor prognosis, usually distal extremities or guts of young patient. Pecoma perivascular epithelioid cell tumor has hybrid melanocytic myogenic differentiation, so HMB45 and SMA, but again, rarely with S100. Usually this is seen in the GYN tract. We don't see these very often in the soft tissue, but this is part of this family, right, of tumors that have combined melanocytic myogenic differentiation. Epithelioid tumors with myxoid stroma include one myoepithelial tumors, by definition, should have either keratin or EMA and one of the myoepithelial markers, including something contractile like calponin or SMA, a neural crest like S100 or SOX10 or GFAP. Occasionally, they can have EWSR rearrangement and rarely INI1 loss. Malignancy is defined by cytomorphology rather than infiltration because sometimes they can be circumscribed and still malignant. Chordoma, of course, at the opening and closing of the notochord, base of skull and sacrococcyx, phyzoliferous or bubbly cells with myxoid background. Here's a nice gelatinous tumor coming off the base of the sacrum. Keratin, EMA, S100, and ding, 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 highly specific being brachyury. They can dedifferentiate into D-diff chordoma as seen on the bottom left. And lastly, for myxoid stromal tumors is extraskeletal myxoid chondrosarc. This is probably the hardest to diagnose because it has no particular immunoprofile. It just has a morphology and absence of the other immunomarkers, so you'd want to confirm with NR4A3 gene rearrangement. This is generally aggressive young patients, young adults. If you're lucky enough to see it on gross, it has this nice yellow lobulated yellow-red appearance. Chart for your review, chart for your review, chart for your review. If you have a few minutes, we can talk about how many people are still left on the, are people still here?
Yeah, there's about 7. You can keep going.
All right, I'll keep going. We're almost done, I promise. There's a lot in soft tissue. 1 hour is tough. Okay, so fibrous histiocytoma, dermatofibroma, raised lesion, hyperpigmented, reflective of elongated epithelium with hyperpigmentation, stromal or dermal storiform appearance with peripheral infiltration into the dermal collagen, usually CD34 negative, except for the maybe little bits at the periphery. You can have variants, including very cellular DFs, including epithelioid or atypical monster. Generally, you want to differentiate from DFSP, which should be diffusely strongly CD34 positive. It should entrap dermal collagen and subdermal fat, unlike DF, which should not have much fat entrapment. Collagen PDGFB gene rearrangement. And here's what fibrosarcomatous transformation, which we already talked about, looks like. Long fascicles, hypercellular, mitotically active. The reason to diagnose fibrosarcomatous transformation is because of risk for risk for metastasis, as opposed to just pure DFSP, which is local recurrence only. Giant cell fibroblastoma variant in kids is immunophenotypically and genetically identical to DFSP, except it has these giant cells with pseudoangiomatous spaces lined by giant cells. JXG in kids, these orange plaques that can regress, but diffuse expansion of dermis and even into subcutis by mononuclear cells and these nice wreath-like giant cells. Atypical fibroxanthoma versus dermal sarcoma. So AFX theoretically, and I say this all with a grain of salt, is a well-behaving but malignant appearing spindle cell lesion in the dermis of sun-damaged skins of elderly. It should have no evidence of dermal, of extension beyond the dermis into the subcutis. It has a pushing border. And if it fulfills all these criteria, it's usually well behaved. However, you can never make this diagnosis on a shave biopsy because guess what? You don't have the deep aspect of it. So do not ever make this diagnosis on a shave biopsy. Because your differential is in fact something like a high-grade dermal sarcoma, which if it infiltrates the subcutis, has necrosis, LVI, PNI, is high grade with the potential for metastasis. And lastly, of course, any spindle cell neoplasm in an epithelial site, you'd want to exclude spindle cell carcinoma and spindle cell melanoma based on IHC or the presence of superficial in situ or in situ melanoma or in situ carcinoma. Okay, that's my caveat. Don't diagnose AFX on a shave biopsy. Plexiform fibrohistiocytic tumor, triphasic tumor of kids, spindle cells, kind of myogenic looking in fascicles, mononuclear epithelioid cells, and osteoclast-like giant cells in the deep dermis subcutis of kids. Giant cell-rich tumors of extraosseous sites, including tenosynovial giant cell tumor, localized or diffuse type, i.e. diffuse type carpeting the joint, formerly called PVNS, mononuclear cells, foamy histiocytes, giant cells, hemosiderin, CSF1 gene rearrangement. GCT of soft tissue kind of looks like GCT of bone, except it's present in the soft tissue, very, very rich and very, very multinucleated giant cells with mononuclear cells in the background. Matrix-forming tumors of soft tissue include chondroma, include myositis ossificans, which is a USP6 rearranged tumor like nodular fasciitis, but it has a rim of bone. And very rarely, extraskeletal osteosarc has bone usually in the core rather than at the periphery and is malignant. There's a triphasic mite. Should make osteoid, as you can see here. And getting into the weeds here with some of our few rare tumors, fibrous hamartoma of infancy, groin and axilla of young kids, fibrous tissue that's SMA positive, immature mesenchymal tissue that's SMA negative, and fat. 1, 2, 3. Hemosiderotic fibrolipomatous tumor / myxoinflammatory fibroblastic sarcoma is a spectrum arising usually in the distal dorsal extremities like dorsal foot and hands. If you see a lesion that looks like hemorrhagic, scarred fat, that's HFLT. You might look at it and be like, I don't know, did this person bump their toe? It looks like fat with scar and blood. Well, it could be HFLT. This has TGFB, MGEA5 gene rearrangements and is important because it can transform to this myxoinflammatory fibroblastic sarcoma, which basically looks like a myxofibrosarcoma, right? Curvilinear vessels, background myxoid, but with some increase in inflammatory cell component and these virussite-like or Reed-Sternberg-like giant cells that are smattered in and about. This gets graded just like any other sarcoma of the extremities. Okay, phosphaturic mesenchymal tumor. Oh my goodness, we just had one of these in the soft tissue service. It was super cool. If you guys want to see it, ask Herman. This is generally a very rare tumor. If you have a diagnosis of basically clinical syndrome of rickets, phosphaturia, hypophosphatemia, osteomalacia, with a tumor, you can know that this is coming. It can be very hard to diagnose if you do not have this known serologic abnormality. What it looks like is very kind of bland spindle cells with this very grungy so-called microcystic or calcified matrix. And you can do ISH for FGF23. in tissue if you want, or you can just watch after the tumor is resected, the patient's serum FGF23 resolves. So it basically, removing the tumor resolves the serologic abnormalities. And angiomatoid fibrous histiocytoma looks kind of like a nodular tumor in the lymph node rich area like groin and axilla of young adults. It can have this pseudoangiomatous space in the center, and sometimes all you're left with is a very narrow rim of neoplastic cells at the periphery that are kind of plump and epithelioid and EMA CD99 Desmond expression, but you probably are going to want to confirm with EWSR-CREB or other fusions because this is pretty rare and can, in fact, recur and metastasize. Okay, that's it. Question. Yes, you can all look at all the interesting cases we can arrange for that. Are there any other questions?